In your keynote lecture, you will discuss the interdisciplinary team approach, or IDT, instead of the multidisciplinary team approach, MDT, that we're used to hearing about. Why IDT? Are there any fundamental differences between the two approaches?
That's an excellent question, and thank you for asking. Not a lot of people can see the difference. Yes, we're very used to this terminology, to the multidisciplinary team approach terminology. To start with, both of the approaches, multidisciplinary and interdisciplinary, have been used in healthcare and lately in sport, and they're effective. We know that the athlete's care yields better outcomes when a comprehensive approach by healthcare professionals is used. And we know that best outcomes achieved by professionals collaborating in work, learning, mapping out the prognosis and generating new ideas. Although there are clear differences between the two approaches, many educational researchers, practitioners, and clinicians, they use these terms interchangeably. And this is something we're going to discuss there, so it's very important. I'm really privileged to work where I work in state-of-the-art facilities, work for Ministry of Defense. And, you know, in the military environments, the soldiers and elite athletes, they have many similarities. There are similar needs, similar demands in their trainings, physical and mentally, right? For us, the multidisciplinary, interdisciplinary approach is a long tradition. Hence, I feel comfortable and confident to talk about this. But their treatments are always individually tailored. We have goal-based according to their personal needs, and the teamwork, our teamwork, works very close, and everyone is involved in joint problem solving. Now, what is multidisciplinary teams? In multidisciplinary teams, the team of professionals, including representatives of different disciplines, who coordinate the contribution of each profession with very little overlap. These professionals working in parallel, and they have clear roles. Each of those professionals sets their own individual goals with the patients, the athletes, and communicate these goals and outcomes with the rest of the team when it's appropriate. Now, the difference is that with interdisciplinary teams, the participants share the goals and overlap the practice rather than working on a separate discipline-specific goals. These professionals involved in joint problem solving, working beyond their own scope of practice to help the athletes. And here, the treatment goals overlap and collaborate with other disciplines. This way, we have the opportunity to learn from each other's expertise and offer better solutions to our athletes. And there's a regular communication between the athletes, between the team members. Now, the team is working very close, and we're achieving incredible outcomes. Now, so what is happening are the fundamental differences. The multidisciplinary teams work in a team, which is great, but the interdisciplinary teams engage in teamwork, if you can understand what I'm saying. I know it's a bit difficult for us because we apply this model. It's easy to understand. Now, the multidisciplinary care does not emphasize an integrated approach to care, which we want for our athletes. And they're unable to develop a cohesive care plan as each member of the team uses his or her expertise to develop individual goals, care goals. And this is sometimes there's some loneliness there, and this we found out that can confuse the athletes. We will give advice, and these athletes will go and will think what then they do. With interdisciplinary teams, in contrast, each team member builds on each other expertise, as I said before, to achieve common shared goals. And what we do is we make this patient member of the team. We communicate all this information, and we use patient-shared decision approach. And really, it's really important. The other thing is that they're not, it's always us. There's not me. We're not working, we're not isolating in our silos. And this is extremely important. No one is more important. Our patient, our athlete is more important. So we put things together, we're working together, and this is the difference. Not, we will not advise the athlete to do something and then we forget about it. We sit all together and we discuss all these goals. Is that clear?
Yes,
Yeah.
that's very clear. And that's very interesting as well. And actually, that takes me to the next question. So the interdisciplinary approach sounds like an ideal model, but how does that work in practice?
Yeah. Again, what I'm going to say, there are not egos in our practice. It's a fantastic ethos. We're working as a team. No one is more important than someone else. And it is long tradition for us. So we have this experience. Everyone is so valuable in the team. It doesn't matter that I'm the leader of the team. We don't feel that we have leaders there. Everyone has an equal role. So how we set the clinic. In the clinic, the old tradition that the consultant, we have consultants, the senior physicians in the UK, we call them consultants. So the physician will sit in their room, will see the athlete, and then will give direction. It doesn't work that way. The setting of the clinic is as such. We have the physician, the consultant physician, we have the physiotherapist, we have the rehabilitation instructor, sports physician, sport scientist, occupational therapist, podiatrist. All these people, they sit in the clinic. I don't have to examine. I can ask the important questions. The physiotherapist and the exercise instructor will examine, for example, and because we trust each other, it's very important to trust each other, then we sit together and we discuss the case. Of course, we are very well prepared because before the patients that will come, the athletes that will come in the clinic, we do our homework. So we know not what to expect. You never know what to expect, but we have done our homework. And when the patient will come to us, we'll ask the questions, we will listen to them, and then we'll examine them. So according to the needs, maybe we will have extensive ITD. So we'll have a podiatrist, nutritionist, pain consultant, pain psychologist, mental health specialist, if they need vocational occupational therapists, because it's very important. Why? Because one size fits all doesn't apply in sports and exercise medicine and in elite sport as well. Everyone has different needs. This is how you have to look at things.
Yes, I see. Now, you encourage, yes, definitely. So now you encourage people to implement the biopsychosocial approach in sports medicine. What are the benefits of a theory that has existed for more than 40 years? Is this approach something that all trainees should be taught in medical school or during their training?
Exactly. So now this is my biggest passion. And, as a dual trained, being an orthopedic surgeon, this is something we never been able to understand in the past, but it's something that I teach all the time. And yes, of course, we should teach our students in a young age, but the biopsychosocial model, yes, it is the key to success, even 44 years since George Engel back in 1977 argued that the psychological and social factors can influence the biological functioning and play an important role in health and illness. And now in this era where the mental health of the people is getting worse and worse and worse, we can see this happening. And what is this? What is the biopsychosocial model? And what is these factors of affecting, say, I'm a hip consultant, my hip pain. First of all, we have to say that we know that the pain is bidirectional process. The pain can affect our emotions can affect our pain. And this is very important to understand. So if we translate what is the biological? The biological is the age, the gender, the health tissue, the genetics. And it is my body, it's our athlete's body. And if I translate it to hip, it's my groin pain, my hip pain, my impairment, my weakness of the hip. The psychological factors are the mental health, the emotional health, the beliefs, the expectations. So it's my mind, it's our patients, our athletes' mind, their beliefs, their expectations. Is my hip going to be damaged if I do exercise? It's not, but this is what they think. Do I need surgery, and what that means for my career? Stress, anxious, more pain. And the sociological, social factors, what is this? Different social support dynamics, socioeconomics. It's their world. So the sport club, the peers, the support of the family, their friends, and all these factors are important factors that can affect their biological, their problem, their hip, let's say. And for me, the biological approach is just a philosophy of care. It doesn't matter which specialty, it's a philosophy of care. It's beyond sports and exercise medicine, but with others a bit more. It's a philosophy of great importance, which we should not underestimate. How it starts, people, they say, oh, how I do this. And what I say often is like, maybe you do this. If you're an empathetic leader, if you're an empathetic physician, you probably not do this, but you don't know it. So how all starts? Listening to your patients. Not only they're telling you the diagnosis, but they're the most valuable source of information. When they will come in your clinic, you have seen the letters, the referrals, the scans, you know everything about them. But the most valuable source of information is them, how they feel, how this injury made them feel. And quite often what I say to my juniors, look at the world through your athlete's eyes and walk through the world in your athlete's shoes. And then you can definitely approach this, implement this model in your treatment.
Wow, very interesting, Doctor. Now, in your second conference, you're going to talk about REDS. What
Yeah.
exactly is the relative energy deficiency syndrome, and why is that so important to raise awareness?
Exactly, and this is excellent topic, which I never know enough about it, although I am an old physician practicing for 25 years. I graduated sports university and I was athlete myself. And I was only a sports gymnast and ballet dancer when back in 1986, I've heard about this for the first time. So what it is, we talk about impaired physiological functioning caused by an imbalance in energy availability. This imbalance has health implication, but also has performance implication. And this is something we must use, the performance implications, when we talk to our young athletes, because when you're young, you don't want to know about health implications, but you want to know about performance implications. I'm not going to use the definition because I really want to explain that the underpinning etiological factor is the energy deficiency. This is the core base. So it's the relative imbalance between the energy intake, how much we take, versus the energy expenditure of what we call homeostasis, the physical activity of daily living, the sports activity, how much energy these athletes, young and older, spend when they train or they do their activities. And can be athletes, can be performance, just dancers, for example, or people that they're training. You don't have to be an elite athlete to have this syndrome. So we also know now that low energy availability does not affect elite athletes, but affects all the individuals, because nowadays, the last 10 years, we're all more physically active. And a lot of people, they don't define themselves as an athlete. So this is very important message to pass. I can go through how the calories that should consume, but probably It's too much information. We can go through questions later on, but I think that we can discuss more details when I'm there, and I'm happy everyone to come and talk, ask questions, be in touch.
Of course, that would be amazing. Now, things have changed significantly since the 80s and 90s when we only knew about the female athlete triad. Can you tell us about the evolution of science over the years until the recently published IOC consensus statement on REDS?
Absolutely. And as I said before, this is very important for me because I was only a young athlete, gymnast and ballet dancer when Barbara Drinkwater, back in 1986, invented this terminology, the female athlete triad. And this was really evolutionary at this time, and people, they looked at it with thoughts and skepticism, but how ahead was from her, time. So there's a massive evolution of the science since then. And you know that Barbara Drinkwater talked about these three pillars: the disorder eating, amenorrhea, and this will cause osteoporosis. And this is what we knew at this time. Later on, 1992, the American Society of Orthopedic Surgeons defined again the female athlete triad, but they looked at the different aspect, and something is more to their specialty. They said, they talk about the spectrum, but also they talk about this can lead to stress fracture, and this is very important for them. Later on, there was more evolution to the science. Back in 2005, the International Olympic Committee had a position stand and consensus statement, and this was great work by the amazing team. But I think that the real evolution to the science, or the big change, came back in 2007 with a paper from Natif et al. From at ACSM, when now they talk about, not about the triad only, but they talk about a spectrum. They talk about low energy availability, continuum, and interrelationship. What that means, that there is a spectrum. Can be low energy availability and osteoporosis, hormonal issues on osteoporosis, but as you improve and from low energy to reduced energy availability, your hormones are improving and your bone health is improving. Whether if you improve even more and go up to optimal energy availability, then your hormones improving and your bone health is improving, and you have optimal bone health. And this was really, really big difference. Then from that, we're going to a big IOC, International Olympic Committee meeting, 2014. Based on this, they talk about, it was the introduction of the wider term, which now includes the female athlete triad. They're not saying that it doesn't exist, but include in this. And later on, we go to the next step, which is the 2018, which is the big first consensus statement on REDS. And this is when they came with the definition saying that it's not a triad anymore, but it's a syndrome. Relative energy deficiency syndrome refers to an impaired physiological functioning caused by relative energy deficiency, and includes, but is not limited to, metabolic rate, menstrual dysfunction, bone health, immunity, protein synthesis, and cardiovascular health. But since then, the IOC amazing group with led by Professor Moonjoy, Catherine Ackerman, and a fantastic team of professionals, they found out that since 2018, just a few years ago, there have been more than 170 papers, original research publications, which helped to advance the field of REDS. And this is when they started to work on it. And the last few years, they worked really, really hard. and they came up with the new consensus statement that published a few months later. We've been waiting for this for a while, but it was amazing. We had a great meeting, the Female Health in Boston last year, led by Kate Ackerman, and this is the first time we talked, but it was a barcode, so then was published. So what they now say is that the syndrome of impaired physiological and or psychological functioning experienced by female, and male athletes this time, right? And is caused by exposure to problematic, prolonged, and or severe low energy availability. So the detrimental outcomes are not limited to decreased energy metabolism, reproductive function, musculoskeletal health, immunity, cardiovascular. This all can individually and synergistically lead to impaired well-being and increased injury risk and decreased sport performance. And again, performance, I repeat, because the athletes, this is what they're going to listen. And if we want to summarize this for our audience, is we know now more about the additive impact of low carbs availability with low energy availability play important role in the development of relative energy deficiency. There is an overlap of relative energy deficiency and overtraining syndrome. So we should not look individually at them. The course of biomarker responses, problematic low energy deficiency, and in the development of REDS, we improved a lot of the understanding we have of the mental health associations, because there is interconnection. So the relative energy deficiency can cause mental issues, and the other way around. The only arrow goes two ways. And we have now advances in knowledge of REDS in males, which before we didn't know, and was very difficult to communicate this information with male athletes. And of course, very, very important is the IOC RED clinical assessment tool, which is so much easier to use. So you don't have to be expert. So you can download this. It's a tool. We talk about this in Monterrey. We call it the CAT2 tool for screening, and it's 3-step model, very easy to use. I'll give you the code to download and see how it works. Very easy, 3 steps. Initially, step 1 is the RED screening. Step 2, the RED severity risk certification. And step 3 is the clinical diagnosis and treatment. And you know very well what to do. You can't go wrong with this tool, and you can have it in your clinic. Sorry about this. I'm very passionate about it.
No worries. I can see that, and I love it.
IOC people group did amazing amount of work, and we need to really share this information, especially within the young clinicians.
Yes, definitely. Thank you, doctor, for that information. That was brilliant. So now, as an orthopedic surgeon and sports medicine consultant who specializes in hip and groin, I assume you see many stress factors related to REDS. Can you give us some tips on what clinicians should know about this?
Yeah, absolutely. Another passion of me, because people, they think that hip fractures are not common. They are, unfortunately. First of all, if we focus, we know that we have many health implications, but if we focus the health implication to bone health, we know that hypoestrogenemia has negative impact on bone health. We know that low energy availability has negative impact on bone independent of low estrogen. There's massive risk of stress fractures, and we know that low energy availability alters endocrine function, which with direct and indirect impact on bone health, even in male athletes. So there's a lot of evidence out there to know how REDS can affect the bone health. So first of all, hip stress fractures are not, Often, unfortunately, because we don't know that too often, misdiagnosed. And when are diagnosed, they're mistreated. And early diagnosis and appropriate knowledge is very, very important. First of all, we need to grade the bone stress to appropriately manage them. As you know, the last decade, it became very fashionable for people to run marathons and run more than before, but their bodies are not ready, are underprepared, let's say, or the knowledge regarding energy availability and how to train is limited. So although we know that stress fractures can occur as a result of overuse syndrome, injury to the bone, when the runners will build up their intensity and volume without the preparation. Also, we see more stress fractures because of the REDs. And this is something people are not familiar. So, so for these young people, it's challenging to diagnose. We need to know, first of all, the reason, of course, and we need to know if these people meet their energy needs to maintain bone health. Then what people do, they send these athletes at home or young people at home and say, do nothing for months and months and months, which is really, really not a great advice without checking their hormone status and all that. We know that strength and power training helps osteogenic activity, so we should not send these people home doing nothing and without investigate them. So if I go and think about some trips, remember first of all that low energy availability is common and plays a big role, pivotal role in the development of REDs. Our goal, if we know that this REDs there, is to achieve optimal energy availability for health and performance. Have high index of suspicion when we have amenorrhea and when we have recurrent stress fractures with people, athletes, endurance athletes, aesthetic sports, light category. If we have stress fracture, empower strengthening and ensure osteogenic activity for bone health, then allow the training and sport participation in a safe manner, and the IOC consensus can help this. Determine the level and the care of and monitor. Again, the treatment involves interdisciplinary team. Remember that absence of period is not an adaptation of sport. It is a marker of energy deficiency. What else? Make sure that there is adequate energy intake. Optimize the stored energy, restoration of menstruation if it is not there, the calories, the calcium, vitamin D. Then monitor and adjust the load as is necessary. And monitor the symptoms of overtraining. As we said before, it's very important. Encourage adequate recovery time. It's very important when you plan a competitive schedule. Then for the clearance and RTP, return to sport, the decisions are challenging, but the guidelines can help risk stratify athletes, the IOC consensus statement and the tool we discussed before. Educate and be educated, what we do now and what you will do with your conference. And probably the screening is probably the best time to identify athletes are at risk and always check nutrition. For hip fractures, don't think only overload, think about hormones, think about energy availability. And this can be, it's not always intentional. Most of the people, they don't know. So it's unintentional.